So, ladies and gentlemen, we've got time for just a couple of questions. We've got a couple of girls in the audience with microphones. If you want a question, Stephen, if you'd like to come and join us on stage. So if you've got a question, just put your hand in the air. The girls will find you with the microphone. Stephen's coming as well, so you can ask either Stephen or Lindsay.
So the question that I had was from personal experience. 11 years ago, I was having an emergency C-section, and I could see that best practice wasn't being followed, nice guidelines, particularly in the use of big razors and things like that. I could see that things were going wrong. As a patient, I felt like I had no power to, intervene or say anything. So how can we perhaps empower patients to be able to challenge and be educated about what should be best practice, so that they can then question, what's being done to them and have that empowerment, if you like. And also, in response to my challenging at the time, it was that it was surgeon preference, and it was just guidelines, it was just a recommendation, and it was up to the surgeon. So how can we sort of change those attitudes, and have attitudes like that changed in that period, do you think?
Basically, I think a lot of it is down, as you said, to individual surgeons' choice. But I think as we've got the internet and we're trying to engage more and more with patients, they are far more aware of what should and shouldn't happen. They do observe things, and some patients will actually question it. But it's a question of also practitioners working in that environment to encourage changes. And I used to question, a surgeon that I was working with used to catheterize every patient that he did a hysterectomy on. And I said to him, I don't want you to bite my head off, but why are you doing this? Because I've always done it that way. And I said, but you're potentially then introducing an infection into a patient by putting a device in that they don't need to have, because he was only doing it for comfort, so they didn't have to get out of bed. So why would you do that? So it's about them being able to question and have a rationale when you're able to do that, to change practice.
Is there anything that we could do to educate patients as well about what best practice actually looks like? Because most people, I was fortunate enough to know that what was being done to me wasn't following nice guidelines, but most people wouldn't know that. Is there a way that we can empower patients before they go into surgery to understand what they can expect, what is good practice, and be able to, challenge when they see that things are being done to them that, shouldn't be happening, basically?
I think there's leaflets out there, and I think part of the pre-assessment process, they should be encouraged to actively engage and ask questions. And if you don't inform the patient, some patients don't want to be informed, they don't want to know, they just want to know, I'm going in for an operation, they're going to do this, and that at the end of it, everything's going to be okay. But I think they should make it part of an informed consent process. And there's even some people that won't actually operate in surgeons, certain surgeons that won't, unless they're actually involved in it. Particularly as a cardiac surgeon that I knew, he wouldn't go there, and that's why he had a reduced surgical site infection rate, because the patients were on board with what they had to do. And maybe that we need to inform patients more in a different way. There's all different techniques you can use, visual things you can use, podcasts, all sorts of ways. But are they going to read it and understand it? And then it's reinforcing it and embedding it so they understand it and they can work with it.
Excellent, thank you.
Any more questions? There's a lady down here.
It's a question to both of you, actually. How do you instill psychological safety amongst staff and a bit of a just culture? You're both talking around, so specifically around the surgical site infections, having that openness to be honest when something's gone wrong, holding your hands up and saying, I'm not sterile anymore. So it's just around how can you bring that into your practice, into trusts, so that there is that psychological safety. And the same, again, to yourself around prescribing practices.
I'll take that one first. I think with prescribing practices, I think we have to acknowledge our limitations, and as a consult service, we first start with we want to get the insight from the prescriber. So I think there's no such thing as a bad prescriber. I think all prescribers want what's best for their patient, and it's important that we first recognise that, identify what their concerns are, and then start working backwards. So usually there's a very good reason why they've gone slightly off-piste with their prescribing. Asking those questions, identifying their concerns and fears, and then sort of talking them backwards and walking them back. So I think that's what we find quite useful. Whereas I think if you come at them head on and quite attritional, say, you're wrong, I'm right, it doesn't help anybody, and that gets very difficult relationship to work in for both of us. It's not long-term sustainable. So I think coming at them from the side on, arm around the shoulder, and getting their understanding, and often they will have good reasons for it, and maybe it's a educational deficiency, and you can sort of support that and say, well, actually, did you know this? And how about we try this instead? I find that works quite well, and it's much less abrasive and leads for a much better working relationship.
I think from having been in practice, often working against consultants, I'm not afraid of challenging as long as I've got the evidence base of why I'm arguing my point. And equally, I'm an advocate for the patient. If I observe bad practice, I should be able to speak up and say something, but it's about doing it in the right way. You know, some people do it in the wrong way and they shout and they carry on, but I think you've just touched that, or I think you've just decontaminated this, and I think you need to change that and be part of that process. I mean, I once saw an ENT surgeon just go into his pocket, lift his gown up, go in his pocket, put his glasses on when he's doing an ear procedure with it. And I says, well, have you done that far? You just contaminate yourself. And he just looked at me, I always do this. You know, and then I'm in a process of documenting it. So, you know, you could datex it, that, you know, they've actually done that, because obviously if you've said it loud enough, the whole of the theatre would have known it's happened, and it's not acceptable practice. And that's the only way you're going to actually be able to deal with it from that perspective. But as practitioners, we're all responsible in theatre, and if we see bad practice, no matter what our level is, we should be able to raise concern in the appropriate manner and not be punished for it.